Hello there, welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic is pelvic viscera, part 1 of the lecture pelvic viscera. The pelvic viscera include the urinary bladder and parts of the ureters. The reproductive system is there, and the distal part of the digestive system is also there, precisely the rectum. The sigmoid colon and parts of the small intestine extend into the pelvic cavity, but they are abdominal organs rather than pelvic organs. The sigmoid colon is continuous with the rectum anterior to S3 vertebra, that's the third sacral vertebra. I must go on to talk about the urinary organs. Right here is an illustration of the urinary organs. Urinary organs in the males. You have the ureters, precisely the lower part of the ureters, the urinary bladder, and the urethra. Those are the urinary pelvic organs. You also have an illustration of the urinary pelvic organs in the female right here. That's the ureters, the urinary bladder, and the urethra in the female. They are all illustrated there. Now the ureters. The ureters are muscular tubes. The ureters are 25 to 30 cm long. The ureters connect the kidneys to the urinary bladder. The ureters are retroperitoneal. Their superior halves are in the abdomen, and their inferior halves are in the pelvis. The ureters cross the bifurcation of the common iliac artery, and as they do so at the beginning of the external iliac artery. At that point, they pass over the pelvic brim and they leave the abdomen and enter the lesser pelvis. The pelvic parts of the ureters run on the lateral walls of the pelvis, parallel to the margin of the greater sciatic notch between the parietal pelvic peritoneum and the internal iliac arteries. Opposite the ischial spine, the ureters curve anterior-medially, superior to the levator ani, to enter the urinary bladder. The inferior ends of the ureters are surrounded by the vesical venous plexus. The ureters pass obliquely through the muscular wall of the urinary bladder, and they do so in an inferior medial direction, entering the outer surface of the bladder about 5 cm apart. But the internal openings of the ureters into the lumen of the empty bladder are separated by only half that distance, that's 2.5 cm. This oblique passage of the ureters through the bladder forms a one-way flap valve. We like that because it makes urine to flow in one direction, that's from the ureters into the bladder, and it cannot go the other way. The internal pressure of the filling bladder causes the intramural passage to collapse, and this helps in filling of the bladder. You must also know that the contractions of the urinary bladder musculature act as a sphincter, preventing the reflux of urine into the ureters when the bladder contracts, increasing the internal pressure within during micturition. So as the bladder contracts during micturition, the internal pressure within the bladder increases, but there is a sphincter. The contractions of the bladder musculature, in addition to the valve we talked about a moment ago, you also have the bladder musculature contracting and acting as a sphincter to prevent reflux of urine back into the ureters. Urine is transported down the ureters by means of peristaltic contractions. You have a few drops being transported at intervals of 12 to 20 seconds. In males, the only structure that passes between the ureter and the peritoneum is the ductus deferens. It crosses the ureter within the ureteric fold of the peritoneum. The ureter lies posterolateral to the ductus deferens and enters the posterior superior angle of the bladder. It does so just superior to the seminal glands. What about the females? In females, the ureters pass medial to the origin of the uterine artery and continues to the level of the ischial spine, where it is crossed superiorly by the uterine artery. So in females, the uterine artery lies superior to the ureter. The ureter in females passes close to the lateral part of the fornix of the vagina and enters the posterior superior angle of the bladder. What about the arterial supply of the ureters? There are variable branches from the common iliac artery, the internal iliac artery, and ovarian arteries that supply the pelvic parts of the ureters. There is anastomosis along the length of the ureter, and this gives a continuous blood supply. The most constant arteries that supply the terminal parts of the ureter in females are branches of the uterine arteries. Of course, in males, you don't have uterine arteries, so the inferior vesical artery gives branches that supply the terminal parts of the ureters. Table 5 there is a table that gives the details of the arteries that supply the ureters. That's the branches of the common iliac artery, internal iliac artery, branches from the ovarian artery, the uterine artery, and the inferior vesical artery in the male. Now, the venous and lymphatic drainage of the ureters. Veins from the ureters accompany the arteries and have corresponding names. That the veins that drain the ureters drain into the common iliac vein, the internal iliac vein, the ovarian vein, uterine vein, and of course the inferior vesical vein in the male. Lymph drains sequentially from superior to inferior into the lumbar, that's the caval or aortic lymph nodes. Then as you go inferior, you have the common iliac lymph nodes and the external and internal iliac lymph nodes that actually drain the pelvic part of the ureter. So most of the pelvic part of the ureters drain into the external and internal iliac lymph nodes. Innervation of the ureters. The nerves to the ureters come from the adjacent autonomic plexuses, that's the renal, aortic superior and inferior hypogastric nerve plexuses. The ureters are superior to the pelvic pain line. You have afferent pain fibers from the ureters, following sympathetic fibers in a retrograde direction to reach the spinal ganglia and spinal cord segments of T11 to L1 or L2. That is the 11th spinal nerve segments, 12th first lumbar, and it might get to the second lumbar spinal nerve segments. Ureteric pain is usually referred to the ipsilateral lower quadrant of the abdomen, especially to the groin, that's inguinal region. So when you have pain around the groin inguinal region and even the lower quadrant of the abdomen, you must not rule out the ureters. You really need to carry out other examinations like radiological examinations to see how the ureters are faring. Now, heterogenic compromise of the ureteric blood supply. What's that all about? The ureters may be injured in the course of surgery, abdominal surgery, retroperitoneal, pelvic or gynecological surgery. So this could lead to interruption of the blood supply to the ureters. And to prevent this, you really need to identify the ureters and understand their full course through the pelvis before you do such surgery. There is a longitudinal anastomosis between arterial branches to the ureter, and like I mentioned earlier on, This may be adequate to maintain the blood supply along the length of the ureters in case it is tempered with any cause of surgery, but occasionally it might not be adequate because there might be the anastomosis might be overwhelmed. In the course of surgery, you could have traction on the ureters, and this leads to delayed rupture of the ureter. The ureteric segment that is affected becomes gangrenous, and it leaks or ruptures a week to 10 days after surgery. When you need to apply traction in surgery, you need to really apply the traction with great care. You need to realize that the blood supply to the abdominal segment of the ureter approaches from a medial direction, and the pelvic segment approaches from a lateral direction. So the ureters should be retracted accordingly so that you don't cause more damage to the patient than he or she came in with. Now, what about ureteric calculi? The ureters are expansile muscular tubes that dilate if obstructed. So when you have acute obstruction of the ureters, it could result from ureteric calculus, that's like a stone, pebble. The symptoms you have and the severity that occurs depends on the location of the calculus, the type, and the size of the calculus. It also depends on whether it is smooth or spiky. Although passage of small calculi usually causes little or no pain, larger ones produce severe pain. The pain caused by a calculus is colicky pain. It resembles the colonic pain, and it results from hyperperistalsis in the ureter superior to the level of the obstruction. Ureteric calculi may cause complete or intermittent obstruction of urinary flow. The obstruction may occur anywhere along the ureter, but it occurs most often at 3 sites. That's the 3 sites where the ureters are normally relatively constricted. One of such sites is the junction of the ureters and renal pelvis. The second site is where the ureters cross the external iliac artery and pelvic brim. And the third site is the extent where you have the ureters passing through the wall of the urinary bladder. The presence of calculi may be confirmed by abdominal radiographs, or you could do what we call intravenous urogram. Ureteric calculi may be removed by open surgery. You could do endoscopy, that's endourology. Could also do lithotripsy. Lithotripsy uses shock waves to break up the stone into small fragments that can be passed in the urine. Now, let me talk about the urinary bladder. I'm still talking about pelvic urinary organs. I'm done with the ureter, and I need to talk about the urinary bladder. Right here is an illustration of the urinary bladder of the male. This is the sagittal section through the pelvis of the male, and you can see the urinary bladder there. You also have a section through the urinary bladder. The urinary bladder is a hollow viscous with strong muscular walls. The urinary bladder is characterized by its distensibility. So it's highly distensible. It can expand. As it fills up with urine, it expands. The urinary bladder is a temporal reservoir for urine, and it varies in size, shape, position, and relationships according to its content. That's how much urine you have in there, and the state of neighboring viscera. When empty, the adult urinary bladder is located in the lesser pelvis, lying partially superior to and partially posterior to the pubic bones. The urinary bladder is separated from these bones by what we call the potential retropubic space of rhesus. The urinary bladder lies mostly inferior to the peritoneum. It rests on the pubic bones and pubic symphysis anteriorly, and the pelvic floor posteriorly. The bladder is relatively free within the extraperitoneal subcutaneous fatty tissue, except for its neck. At the neck, the urinary bladder is held firmly by the lateral ligaments of the bladder and the tendinous arc of the pelvic fascia, especially its anterior components. Puboprostatic ligaments is there in the males, and then in the females you have the pubovesical ligaments. In infants and young children, the urinary bladder is in the abdomen even when empty. The bladder usually enters the greater pelvis by the age of 6 years. However, it is not located entirely within the lesser pelvis until after puberty. An empty bladder in an adult lies almost entirely in the lesser pelvis. Its superior surface level with the superior margin of the pubic symphysis. So the superior surface level is at the same level with the superior margin of the pubic symphysis. As the bladder fills, it enters the greater pelvis as it ascends in the extraperitoneal fatty tissue of the anterior abdominal wall. In some individuals, a full bladder may ascend to the level of the umbilicus. At the end of micturition, what happens? The bladder of a normal adult contains virtually no urine. When empty, the bladder is somehow tetrahedral in shape, and externally it has an apex, body, fundus, and neck. The bladder's four surfaces, that's the superior, the posterior, and then you have two inferior lateral surfaces. These four surfaces are most apparent when viewing an empty contracted bladder. That's when the bladder is empty and contracted, you can appreciate the four surfaces. And such empty contracted bladder, when you remove it from a cadaver, you see that the bladder appears with a boat shape. The apex of the bladder points towards the superior edge of the pubic symphysis when the bladder is empty. The fundus of the bladder is opposite the apex. It's formed by the somehow convex posterior wall. The body of the bladder is the major portion of the bladder between the apex and the fundus. The fundus and inferior lateral surfaces meet inferiorly at the neck of the bladder. You have the bladder bed formed by the structures that directly contact it. On either side, the pubic bones and the fascia covering the levator ani and the superior obturator internus lie in contact with the inferior lateral surfaces of the bladder. Don't forget that only the superior surface is covered by peritoneum. In males, you must not forget that the fundus of the bladder is separated from the rectum centrally by only the facial rectovesical septum, and laterally the separation is by the seminal glands and ampullae of the ductus deferens. What about the females? The fundus of the bladder in females is directly related to the superior anterior wall of the vagina. The bladder is enveloped by a loose connective tissue. So it's enveloped by a loose connective tissue. It's also covered by this loose connective tissue is actually what we call the visceral fascia. So the bladder is enveloped by the visceral fascia. The walls of the bladder are composed of the detrusor muscles. Then towards the neck of the male bladder, the muscle fibers form the involuntary internal urethral sphincter. The sphincter contracts during ejaculation to prevent retrograde ejaculation of semen into the bladder. So these sphincters, the involuntary internal urethral sphincter in male has to contract during ejaculation so that semen does not go into the bladder. Some fibers run radially and assist in opening the internal urethral orifice. Some fibers of the internal urethral sphincter run radially and assist in opening the internal urethral orifice. In males, the muscle fibers in the neck of the bladder are continuous with the fibromuscular tissue of the prostate. But in females, these fibers are continuous with the muscle fibers in the wall of the urethra. The ureteric orifices and the internal urethral orifice are at an angle of the trigone of the bladder. The ureteric orifices are encircled by loops of detrusor musculature, and this tightens when the bladder contracts to assist in preventing reflux of urine into the ureter. The uvula of the bladder is a slight elevation of the trigone. It is usually more prominent in older male owing to the enlargement of the prostate, that's precisely the posterior lobe of the prostate. Arterial supply of the bladder. The main arteries supplying the bladder are branches of the internal iliac arteries. You have the superior vesical artery supplying the anterior superior part of the bladder. In males, the inferior vesical artery supply the fundus and neck of the bladder. In females, the vaginal arteries replace the inferior vesical arteries and send small branches to the posterior inferior parts of the bladder. The obturator and inferior gluteal arteries also supply small branches to the bladder. Venous and lymphatic drainage of the bladder. The names of the veins correspond to the arteries I mentioned a while ago, and the veins are tributaries of the internal iliac veins. In males, the vesical venous plexus is continuous with the prostatic venous plexus, and the combined plexus, that's the vesical and the prostatic venous plexus, combine to envelope the fundus of the bladder and prostate. They also envelope the seminal glands, the ductus deferens, and the inferior ends of the ureters. This venous plexus also receives blood from the deep dorsal vein of the penis, which drains into the prostatic venous plexus. The vesical venous plexus is the part of the plexus complex that is most directly associated with the bladder itself. So the vesical venous plexus mainly drains through the inferior vesical veins into the internal iliac veins, but it may drain through the sacral veins into the internal vertebral venous plexuses. In males, the vesical venous plexus envelopes the pelvic parts of the urethra and the neck of the bladder. The vesical venous plexus receives blood in females from the dorsal vein of the clitoris and communicates with the vaginal or ureterovaginal venous plexus. In both male and female, lymphatic vessels from the superior-lateral aspects of the bladder pass to the external iliac lymph nodes, whereas the lymphatic vessels from the fundus and neck of the bladder pass to the internal iliac lymph nodes. Some lymphatic vessels from the neck of the bladder drain into the sacral or common iliac lymph nodes. Innervation of the bladder. Sympathetic fibers are conveyed from the inferior thoracic and upper lumbar spinal cord levels to the vesical plexuses, what we call the pelvic plexuses. And these sympathetic fibers are conveyed via the hypogastric plexuses and nerves. You also have parasympathetic fibers from sacral spinal cord levels, and these are conveyed via the pelvic splanchnic nerves and the inferior hypogastric plexus. The parasympathetic fibers are motor to the detrusor muscle, and they are inhibitory to the internal urethra sphincter of the male bladder. So when visceral efferent fibers are stimulated by stretching, the bladder contracts reflexly, the internal urethra sphincter relaxes in males, and urine flows into the urethra. So as one gets used to toilet training in growing up, one learns to suppress this reflex when one does not want to urinate. The sympathetic innervation that stimulates ejaculation simultaneously causes contraction of the internal urethra sphincter to prevent reflux flow of semen into the bladder. A sympathetic response at moments other than ejaculation, that's the one that is done self-consciously when standing at the urinary in front of a waiting line, can cause the internal sphincter to contract, and this hampers the ability to urinate until parasympathetic inhibition of the sphincter occurs. There are presynaptic parasympathetic fibers to the bladder, and these come from the neurons in the S2, S3, and S4, that's the second, third, and fourth sacral spinal cord segments. And these fibers pass from the anterior rami of spinal nerves S2, S3, S4, that's the second, third, and fourth spinal nerves, via the pelvic splanchnic nerves and the inferior hypogastric and vesical, that's the vesical plexuses. The vesical plexuses are also called the pelvic plexuses. And I'm talking about the presynaptic parasympathetic fibers to the bladder. I say they arise from neurons in the S2, S3, and S4 spinal cord segments, and these pass from the anterior rami of spinal nerves S2, S3, S4 via the pelvic splanchnic nerves and inferior hypogastric and vesical plexuses, and they go to the bladder. The vesical plexuses are also called the pelvic plexuses. There is synapses with postsynaptic neurons located on or near the bladder wall. Then you also have visceral efferent fibers conveying reflex information and pain sensation from subperitoneal viscera, that's inferior to the pelvic pain line. Such visceral efferent fibers conveying reflex information and pain sensation from subperitoneal viscera, that's inferior to the pelvic line, follow parasympathetic fibers in a retrograde manner to the S2, S3, S4 spinal ganglia, whereas those conducting pain from the bladder roof, that's superior to the pelvic pain line, follow sympathetic fibers retrogradely to the T11, L1, L2, or L3 spinal ganglia. The pelvic, that's the sacral sympathetic trunk, primarily serves the lower limb. You have somatic nerves distributed also from the pelvis to the perineum. Sensory fibers from the bladder are visceral. Then you have reflex efferents following the course of parasympathetic fibers, and they transmit pain sensations that comes from over distension of the bladder, for example, They transmit such pain sensations from the inferior part of the bladder. The superior or the roof, the superior surface or roof of the bladder is covered with peritoneum and therefore is superior to the pelvic pain line. Thus, you have pain fibers from the superior part of the bladder following the sympathetic fibers in a retrograde manner to the inferior thoracic and upper lumbar spinal ganglia. That's the T11 to L2 or L3. Cystocele hernia of the bladder. What is that? Loss of bladder support in females by damage to the perineal muscles or the associated fascia can result in herniation of the bladder into the vaginal wall. A cystocele may also result from prolapse of pelvic viscera secondary to injury to the pelvic floor during childbirth. What about suprapubic cystotomy? You must know that the superior surface of the empty bladder lies at the level of the superior margin of the pubic symphysis. I said that before. But despite that, as the bladder fills, it extends superiorly above the symphysis into the loose areolar tissue between the parietal peritoneum and anterior abdominal wall. The bladder then lies adjacent to this anterior abdominal wall without the intervention of peritoneum. So, the distended bladder may be punctured, and we call that suprapubic cystotomy. It could be punctured or approached surgically superior to the pubic symphysis. And you do that, for example, in introduction of indwelling catheters or instruments. If you want to do that without traversing the peritoneum and entering the peritoneal cavity, you can do the suprapubic cystotomy. Urinary calculi, that's foreign bodies and small tumors, may also be removed from the bladder through a suprapubic extraperitoneal incision. Guess what? Because of the superior position of the distended bladder, it may be ruptured by injuries to the inferior part of the anterior abdominal wall. It may also be ruptured by fractures of the pelvis. The rupture may result in the escape of urine extraperitoneally or intraperitoneally. Rupture of the superior part of the bladder tears the peritoneum, resulting in extravasation, that's passage of urine into the peritoneal cavity. Posterior rupture of the bladder usually results in passage of urine extraperitoneally into the perineum. Now I need to talk about cystoscopy. The interior of the bladder and its three orifices may be examined with what we call a cystoscope. You need to know that during transurethral resection of a tumor, for example, the instrument is passed into the bladder through the urethra. Then high-frequency electric current is used to remove the tumor in small fragments that are washed from the bladder with water. Let me discuss the proximal male urethra. I'm still talking about the urinary pelvic organs. Now the proximal male urethra. Right here is an illustration of the urethra in the male. It's actually the proximal part of the urethra in the male that is in the pelvis. The male urethra is a muscular tube. It's 18 to 22 cm long. The male urethra conveys urine from the internal urethral orifice of the urinary bladder to the external urethral orifice. The external urethral orifice is located at the tip of the glans penis in males. The urethra also provides an exit for semen. You remember semen is made up of sperms and glandular secretions. In the flaccid state, that's in the non-erect state, the urethra has a double curvature. So when we want to describe it, the urethra is actually divided into four parts. The distal intermediate part and the spongy urethra are actually part of the perineum. Then the intramural part of the urethra, that's the pre-prostatic urethra, is what I want to talk about now. That's the part in the pelvis. The intramural part of the urethra, that's the pre-prostatic urethra, varies in diameter and length depending on whether the bladder is filling. When the bladder is filling, the bladder neck is tonically contracted, so the internal urethral orifice is small and high. Urethral orifice is small and high. So the intramural part of the urethra, that's the pre-prostatic urethra, varies in diameter depending on whether the bladder is filling or emptying. When the bladder is emptying, the neck of the bladder is relaxed, so the orifice is wide and low. So that's the emptying internal urethral orifice is wide and low. Now, the most prominent feature of the prostatic urethra is what we call the urethral crest. It's a median ridge between bilateral grooves. The bilateral grooves are the prostatic sinuses. Then there are secretory ducts of the prostate. You also have the secretory ducts of the prostate, the prostatic ducts open into the prostatic sinuses. The seminal corniculus is a rounded eminence in the middle of the urethral crest with a slit-like orifice that opens into a small cul-de-sac that is called the prostatic utricle. The prostatic utricle is the vestigial remnant of the embryonic uterovaginal canal. So that is what you have in the male. The surrounding walls of this prostatic utricle in females, what you have in females actually is the uterovaginal canal. In the males, what you have there is prostatic utricle. So in females, you have what we call the primordium of the uterus and a part of the vagina surrounding the embryonic uterovaginal canal. But in males, what you have is the prostatic utricle. That's by the wayside. The ejaculatory ducts in males open into the prostatic urethra via minute slit-like openings. These openings are located adjacent to, and at times occasionally you have them just within the orifice of the prostatic utricle. So the urinary and reproductive tracts, they merge at this point. That is, the ejaculatory ducts, I said, opens into the prostatic urethra, and it does so via slit-like openings which are located adjacent to and occasionally within the orifice of the prostatic utricle. So here you have the reproductive tract and the urinary tracts merging. What about the arterial supply of the proximal male urethra? The proximal two parts of the urethra are supplied by the prostatic branches of the inferior vesical and middle rectal arteries. The veins, the venous and lymphatic drainage of the proximal male urethra should not be forgotten. The veins from the proximal two parts of the urethra drain into the prostatic venous plexus. The lymphatic vessels pass mainly to the internal iliac lymph nodes. You have a few lymphatic vessels draining into the external iliac lymph nodes. What about the innervation of the proximal male urethra? The nerves that innervate the proximal part of the male urethra are derived from the prostatic plexus, where you have mixed sympathetic, parasympathetic, and visceral efferent fibers. The prostatic plexus is one of the pelvic plexuses. It's an inferior extension of the vesical plexus, arising as organ-specific extensions of the inferior hypogastric plexus. Now you need to know that the parts of the male urethra I just talked about that you have in the pelvis include the intramural, that's the pre-prostatic urethra, as well as the prostatic urethra. You find those parts in the pelvis. By the wayside, you have other parts of the male urethra, that's the intermediate or membranous part, and the spongy urethra in the perineum. So I don't have business with that today. But the intramural pre-prostatic part of the male urethra and the prostatic urethra in the male are both in the pelvis. So that is what I just talked about. The length of the intramural, that's the pre-prostatic urethra, is 0.5 to 1.5 cm, while that of the prostatic urethra is 3 to 4 cm. Then the extent, the intramural or pre-prostatic urethra in males extends almost vertically through the neck of the bladder. I say males, but females don't have that anyway. We just have urethra, not a pre-prostatic or prostatic, because we don't have prostate. Okay, the prostatic urethra, you have it descending through the anterior part of the prostate, and it forms a gentle anterior concave curve bounded anteriorly by a vertical trough-like part, what we call the rhabdosphincter of the external, that's the external urethra sphincter. So you need to understand the features of the proximal part of the male urethra. That is what you have in the pelvis. The intramural, that's the pre-prostatic urethra, is surrounded by internal urethra sphincter. The diameter and length varies depending on whether the bladder is filling or emptying. I said that before. For the prostatic urethra, its widest and most dilatable part is the widest and most dilatable part of the urethra. It has the urethra crest I mentioned before, with the seminal corniculus flanked by prostatic. The seminal corniculus are flanked by prostatic sinuses, into which the prostatic ducts open. Then of course the ejaculatory ducts open into the corniculus. So I said that here you have the urinary and reproductive tracts merging. Okay, so much so for the male proximal part of the male urethra that is located in the pelvis. Now what can I do but talk about the female urethra? Right here is an illustration of the female urethra. Take a close look. The bladder is also showing in this diagram. You have the bladder and the urethra and the urethra orifice. You can see the female urethra right here in the diagram, which is the female urethra is about 4 cm long and it's about 6 millimeters in diameter, and it passes anterior-inferiorly from the internal urethral orifice of the urinary bladder, posterior and then inferior to the pubic symphysis, and it extends to the external urethral orifice. You can see all that in the diagram. The musculature surrounding the internal urethral orifice of the female bladder is not organized into an internal sphincter. In females, the external urethral orifice is located in the vestibule, directly anterior to the vaginal orifice. The urethra lies anterior to the vagina, forming an elevation in the anterior vaginal wall. Its axis is parallel to that of the vagina. The urethra passes with the vagina through the pelvic diaphragm, and you have the urethra passing with the vagina through the pelvic diaphragm, external urethral orifice, and perineal membrane. So the urethra passes with the vagina through the pelvic diaphragm, external urethral orifice, and perineal membrane. Urethral glands are present, particularly in the superior part of the urethra. I'm talking about the female urethra now, in the pelvis. One group of glands on each side, the paraurethral glands, are homologs to the prostate. These glands, that's the paraurethral glands, have a common paraurethral duct. This duct opens one on each side near the external urethral orifice. The inferior half of the urethra in females is located in the perineum. So it's actually the superior half of the urethra in females that is in the pelvis, and that is what I just discussed. What about the arterial supply of the female urethra? Blood is supplied to the female urethra by the internal pudendal and vaginal arteries. Venous and lymphatic drainage of the female urethra is such that the veins follow the arteries and have similar names. That's the venous blood from the female urethra drains into the internal pudendal and vaginal veins. Most lymphatic vessels from the urethra pass to the sacral and internal iliac lymph nodes, but you have a few lymphatic vessels from the distal urethra draining into the inguinal lymph nodes. Of course, those ones are in the perineum. Innervation of the female urethra is such that the nerves to the urethra arise from the vesical nerve plexus and the pudendal nerve. The pattern you see here is similar to what you have in the male, just that you don't have the prostatic plexus here. There is no prostatic plexus, and of course there is no internal urethral sphincter. There are visceral efferents from most of the urethra in the female running in pelvic splanchnic nerves, but the termination receives somatic efferents from the pudendal nerve. Both the viscera and the somatic efferent fibers extend from cell bodies in the S2 to S4 spinal ganglia. That is where you have the second, third, and fourth spinal. Now I'm curious. I think I really want you to know the clinically significant differences between male and female urethra. Both are illustrated here. So let's take a close look at the male and female urethra. That's the proximal parts are actually what you have in the pelvis. So let's look closely. Take a very close look. Take a very close look at the diagrams. I have mentioned some of the differences you have in the course of my presentation. Just a while ago, I told you that in the female you don't have internal urethral sphincter. So you must know that the female urethra is distensible because it contains considerable elastic tissue as well as smooth muscle. So the female urethra can be easily dilated without injury. Hence, the passage of catheters or cystoscopes is easier in females than in males. Infections of the urethra and especially the bladder are more common in women because the female urethra is short, more distensible, and is open to the exterior through the vestibule of the vagina. So that is a minus for us. While the females have the advantage that it's easy to pass catheters or cystoscopes because of the distensibility of the urethra. There is a disadvantage that the infections of the urethra and the bladder are more common in women because the female urethra is short, more distensible, and is open to the exterior through the vestibule of the vagina. I really appreciate you for listening. Don't forget to subscribe to this channel. Goodbye for now.